Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, Medical Editor at MIMS Learning. Joining me in the studio today is my colleague, Deputy Editor Rhiannon Ashman.
Hi Sangeeta.
Today let's dive deep into a subject that every GP and healthcare professional who works with children would encounter on a regular basis: pediatric skin conditions. We'll talk about some run-of-the-mill benign conditions as well as something more concerning and potentially difficult to treat, like infections, allergy, and systemic illnesses.
Yes, everyone knows that skin is the largest organ in the human body, but diagnosing skin conditions can be a large challenge. I've looked after our dermatology education on MIMS Learning for years, but I still get nervous every time one of my kids gets a rash, which is quite often for my littlest, who is very prone to rashes. I think that's another part of this, isn't it, Sangeeta? It's not just the clinical conundrum of diagnosing skin conditions in children, but it's the fact that they can be really upsetting and concerning for parents and carers.
Yeah, I'm very familiar with that anxiety as a parent with a rash-stricken child. But if you're a GP or a dermatologist, this is the episode for you. We're going to look at some common presentations in newborns, infants, and older children and discuss their differentials and get some practical management tips so you can apply them in your practice. So let's get started. When I think of skin conditions, the first thing that springs to mind is scarlet fever. We have a great module on the topic by Dr. Pipin Singh. In the module, he goes into quite a bit of detail about the presentation, symptoms, investigation, and management of scarlet fever.
Yeah, I think there's probably a good reason, Sangeeta, isn't there, why you thought of that? Because a couple of years ago, in 2023, the UK saw a record high number of scarlet fever cases. Predictably, both of my children had it. Did any of your children get it?
No, mine didn't, surprisingly. We escaped.
Fortunate escape. So things started to settle a bit in 2024, but even so, last year the number of cases was still above the 5-year average. So GPs have likely seen a lot more of this than they had in the past.
Yeah, and recognizing the rash early is key to diagnosis. It's caused by group A streptococci, as you probably already know. That's the same one that's responsible for IgAS infection.
And we know that scarlet fever tends to affect children aged from 5 to 15 years. Typically occurring in the winter and the spring. After the symptoms of fever, sore throat, vomiting, headache, myalgia, malaise and abdominal pain, it takes 12 to 48 hours for the rash to appear. It tends to start on the neck and then extend down to the trunks and limbs. The rash is more prominent where the skin folds at the neck, groin and axillae, showing deep red lines or pastilles lines. There's no rash on the palms of the hands or the soles of the feet.
Another feature to note is that the erythematous rash blanches with pressure and leads to dry, rough, almost sandpapery skin.
There's also the strawberry tongue, of course, where the tongue becomes heavily coated, and then when the coating sloughs off, it leads to a shiny red strawberry tongue.
What are the differentials for scarlet fever? Surely a rash and a fever can mean loads of other things.
Yeah, the differentials are pretty wide, as is often the case with paediatric skin conditions. These might include tonsillitis, fifth disease, rubella, and Epstein-Barr virus. And the module gives an extensive list of the differential diagnoses. But the good news is that with scarlet fever, the recovery is quite quick, thanks to the modern miracle that is antibiotics. But it's still important to diagnose and treat this condition properly because there are some potential complications, including bronchopneumonia and rheumatic fever.
That was scarlet fever. Let's now switch gears to neonatal dermatology. Newborn skin is fraught with problems.
Yes, the newborn's immune system is not fully developed. Plus, their skin's much thinner than that of an adult. So that's why they're much more vulnerable to skin infection, and it can be detrimental if the skin barrier is disrupted. So let's start with something that's fairly common: erythema toxicum neonatarum.
I'm familiar with this condition, but just from the name, it sounded pretty scary. So I wondered why something so benign and self-limiting would have toxicum in the name. So obviously I looked it up. I found out that the name was first used by Dr. Carl Leiner in 1912 because he believed that the rash was caused by enterotoxins.
Interesting. So this red rash shows up soon after birth, from between 1 to 4 days after birth up to 10 days. The lesions are 2 to 3 millimetre macules and papules that evolve into pustules. They appear on the face, trunk and proximal extremities typically, but they can occur anywhere except for the palms of hands and soles of the feet. And as you said, Sangeeta, it's self-limiting. It usually only lasts 2 to 3 days.
No treatment is indicated in erythema toxicum neonatorum. There are some differentials for GPs to consider, though. These include transient pustular melanosis, a condition in which pigmented macules and pustules are present at birth, certain viral infections like herpes, or fungal infections such as candida, which can be identified by a Zank smear, which will show mainly eosinophils. And finally, acropustulosis of infancy, which may be considered because of the presence of pustules, but the location and type of pustules seen in acropustulosis of infancy would differentiate it from erythema toxicum neonatorum.
Another common skin presentation in newborns that generally doesn't require treatment are vascular birthmarks. So vascular birthmarks categorised as either vascular tumours, of which infantile hemangiomas are the most common example, or vascular malformations. For example, a port wine stain birthmark is an example of a capillary malformation. So the name birthmark suggests that they're present at birth. Is that right, Sangeeta?
Yeah, that's right. So vascular malformations are present at birth, although they may be quite subtle at the time. They do not regress and they persist throughout life, but they can also be triggered by trauma or puberty later on in life.
And I said a second ago that they generally don't require treatment, but some of them do. Can you tell us a bit more?
Yeah, so most of the times they're harmless, but a minority of vascular malformations can have significant associations. For instance, vascular anomalies can be complicated by additional symptoms, including soft tissue or skeletal abnormalities, such as leg length discrepancies and segmental hypertrophy. The author of this learning module, pediatric dermatologist Dr. Rakhi Ramesh, says that vascular malformations is an area of pediatric dermatology where our understanding has developed significantly in the last 2 decades. And as we learn more, we realize the importance of a basic understanding of these disorders to ensure early recognition, which can lead to a rapid and, in some cases, life-saving treatment for those who may go on to develop complications.
Those are 2 common presentations in newborns that we've just talked about, but baby acne, which is also covered in this learning module, is a presentation that's quite uncommon. In fact, it affects only 2% of children, which I have to admit I was quite surprised about because it's one of those things that people talk about a lot. It also affects little boys more than little girls, and it can occur any time from 6 weeks to 12 months of age. Most commonly, you'd see infantile acne on the cheeks, but it can also appear on the chest and back.
And usually this is mild to moderate with open comedones, inflammatory papulopustules, and less commonly nodules, cysts, and scars. Post-inflammatory hyperpigmentation may be more significant in infants with darker skin types.
And an important consideration for children with infantile acne is to examine them for evidence of virilization because of the possibility of underlying endocrinopathies, such as congenital adrenal hyperplasia. So what are some of the differentials for infantile acne, Sangeeta?
Some of the main ones are papulopustular rosacea, idiopathic facial aseptic granuloma, which is on a spectrum of childhood rosacea, and keratosis pilaris. Molluscum contagiosum can also be mistaken for baby acne.
In general, most cases of infantile acne have a moderate course, requiring no treatment and resolving within 6 to 12 months of the initial onset. However, some cases can cause scarring and can be severe enough to warrant initiation of medication. And topical treatment would be the same as for acne in adolescents and adults. But speaking of skin findings that can look concerning but are actually not that worrisome, there's also congenital dermal melanocytosis. And this used to be called Mongolian blue spot, but that term's not used anymore. How does this usually present?
So these present from birth and appear as flat blue-gray or green areas of discoloration. They're seen most commonly in the lumbar, sacral, or gluteal regions or in the shoulders. Reassuringly, this is benign and it fades when the child is around 2 years of age. The lesions can be pretty extensive and it's seen most commonly in Asian and Black babies of both genders.
And these are a little contentious, aren't they? They need to be approached carefully. They can startle both parents and healthcare professionals because they look like bruises. And unfortunately, because of their appearance, they can raise the suspicion of physical abuse, particularly in geographical areas that have predominantly white populations where healthcare professionals may be less familiar with these presentations of conditions normally prevalent in skin of colour.
Yeah, and this is why it's all the more important for healthcare professionals to become familiar with these so that they can differentiate them from bruises. Properly documenting these lesions is important so that it's on record that they were present at birth to avoid any such confusion. Since you mentioned skin of color, let's get into that. Something that's pretty important to me as a dark-skinned person is how skin conditions can present differently in skin of color. Just as an example, don't go looking for red patches to identify atopic dermatitis on darker skin, as it will look quite different in those individuals than in somewhat lighter colored skin with atopic dermatitis. I know when I get any kind of dermatitis, my skin looks more or less the same, compared to a light-skinned person whose inflamed skin would stand out because of the lighter background.
And eczema, of course, is a really common childhood skin condition. So the authors of a module we've got on paediatric dermatology and skin of colour say that in skin of colour, eczema can be very subtle, as you said, Sangeeta, and can present with darker brown, purple, or even an ashen colour. And apparently papular eczema is more common in darker skin types, particularly on the limbs and the periumbilical area. Follicular accentuation is more frequent also, as are prurigo-type lesions and discoid eczema. Darker skin may also present with a lichen planus type appearance. Children of colour who've had eczema can have post-inflammatory hyper and hypopigmentation, as you said earlier, Sangeeta, and this can last for months to years after the eczema has been resolved. As with all children with eczema, GPs should explore how the condition affects their sleep and school attendance.
Another thing to note is that rather than affecting flexor surfaces, eczema in skin of color affects extensor surfaces and sites like the cheeks, neck, and scalp. And how would you manage eczema, Rhiannon?
So skin of colour or otherwise, management would be the same, and this might include avoiding very hot or cold showers and fragrances, using regular emollients, topical steroids for active flares, and steroid-sparing agents as well for maintenance treatment or for flares. Phototherapy is an option, and oral immunosuppression may be considered in recalcitrant cases. If the child is 6 years or older, dupilumab is approved for moderate to severe atopic dermatitis. Antihistamines can also help in persistent pruritus, especially when sleep is hampered by the itching. So there we have it. We've discussed how some paediatric conditions present differently in skin of colour and how some conditions disproportionately affect this cohort as well.
Yeah, and an example of how some conditions disproportionately affect skin of colour is Kawasaki disease.
This is a multi-system vasculitis that affects children under the age of 6, with a peak incidence at 2 years old. It's thought to have a viral etiology, and most cases have been seen to occur in children of Asian ancestry. So can you talk us through how it presents, Sangeeta?
Yes, absolutely. So Kawasaki disease is associated with a fever for at least 5 days. To suspect Kawasaki disease, you need to have at least 4 of the following symptoms: conjunctival injection of both eyes but without an exudate, changes in the oral mucosa including strawberry tongue, cracked lips, and diffuse mucosal erythema, palmar erythema and induration, peeling skin around the nail. A rash, which is often maculopapular or mobiliform, that shows up on the trunk, lower abdomen, and groin. And finally, swollen lymph nodes in the neck, usually just on one side. There is more skin peeling during the second week, and inflammatory markers like CRP and ESR tend to be elevated. And if Kawasaki disease is not treated, 15 to 25% of cases can have heart complications. And the disease can also sometimes involve the CNS or the gut.
Speaking of viral infections, of which there are obviously quite a few, such as chickenpox has a characteristic vesicular rash, which then develops into pustules and finally crusts over. But saying that if you've seen a child in the early stages of chickenpox, you'll know it isn't always immediately apparent until the disease progresses.
Yeah, Rhiannon, you mentioned the rash, but what are some of the other symptoms of chickenpox?
Well, adolescents with the condition may complain of a prodrome of nausea, myalgia, headache, and loss of appetite, but symptoms in younger children are usually non-specific, although fever is practically universal.
And I always thought it was a once-in-a-lifetime disease, but I was quite surprised to find out that there are groups that are at high risk of recurrence.
That's true. So those with HIV infection, congenital immunodeficiencies, chronic cutaneous or pulmonary disorders, and those who are on high-dose corticosteroids or long-term salicylate treatment are at higher risk of getting chickenpox, even after having had it before.
By the way, did you know that children are contagious 1 to 2 days before the rash even appears? Children become ill 14 to 16 days after contact. And this bit was new to me. Apparently, each child in a family who develops varicella has sequentially worse disease, with the final child being the most unwell.
So although the initial symptoms can be non-specific, the rash is generally quite obvious once it develops. So are there any differentials to consider?
Chickenpox is usually distinctive, but other causes of vesicular rash include herpes simplex, which is not usually disseminated, herpes zoster, which is usually a dermatomal rash, hand, foot and mouth disease, which is caused by the Coxsackie virus, enterovirus, impetigo, and syphilis. Isn't management usually at home because the course is self-limiting in most cases? Because this is what I did when my daughter had it. Just stayed cooped up at home for about a week or two. It feels like forever though.
Yeah, the mainstay of treatment is supportive care, including giving adequate oral fluids and antipyretics and keeping an eye out for possible complications.
And speaking from personal experience, I think the main concern for parents is managing the itch, which can feel like the biggest complication or the biggest issue to manage. And calamine lotion can help alleviate the intense pruritus. By the way, an important thing to note is that ibuprofen is not advisable to manage a fever in chickenpox.
Why is that?
It's because there is a controversy around whether NSAIDs increase the risk of necrotizing soft tissue infection and invasive group A streptococcal infections that's associated with chickenpox. So to avoid any possible risk of these complications, it's advised that ibuprofen is not to be used. Salicylate should also not be used because it's associated with an increased risk of Ray's syndrome.
So I've actually had my kids vaccinated against chickenpox, which we had to pay privately for. But I wonder if GPs might get some questions from parents about the vaccine.
Interesting. What made you go for the vaccine? I've been considering it for my 7-year-old twins that are not exposed to the virus yet.
It's a personal decision, really, isn't it? But honestly, I didn't want the hassle of dealing with poorly children. And I know chickenpox, of course, is mild for most kids, but some can become quite unwell. I had chickenpox when I was about 2 years old, and I still have the scars from it. And I infected my 2-week-old brother, which must have been quite unpleasant for him and for my parents. And also, because of the lack of social mixing during COVID, there were fewer cases in younger children. So a lot of the kids who were babies and toddlers at that time weren't exposed when they normally would have been.
That explains why my 7-year-olds haven't got it yet. So who can get the vaccine on the NHS?
So at the moment, the vaccine's only available on the NHS for people in close contact with someone who has a higher risk of getting seriously ill from chickenpox, such as a child with leukemia or an adult having chemotherapy. You need to have 2 doses given 4 to 8 weeks apart. And the NHS website advises people to contact their GP surgery if they think they or other members of their family need the chickenpox vaccine to protect them or someone they live with. But interestingly, in November 2023, the UK's Joint Committee on Vaccination and Immunisation, the JCVI, recommended that the chickenpox vaccine be added to the routine childhood immunisation programme, although this hasn't been implemented yet. And this reversed a previous decision in 2009 when the JCVI concluded that it shouldn't be implemented. And mainly they made this decision because of cost effectiveness and concerns about possible increases in cases of shingles in middle-aged adults who weren't old enough to receive the shingles vaccine and rely on exposure to circulating varicella to maintain their immunity. This is a concept called exogenous boosting. When I was researching this, I read a paper from September 2024 published in the journal Vaccine, which looked into the attitudes of paediatricians. And I found it quite interesting because the researchers concluded that many UK paediatricians pay for the chickenpox vaccine for their own children and also commonly recommend the vaccine to family and friends when they're asked. So the point I made earlier about not wanting to have to deal with poorly children was made by the authors of this paper, actually, in a much more academic way. And they said, the disease burden of chickenpox is often overlooked due to the perceived expectedness of infection, a perception of mild phenotype, and underestimation of social and financial burden to caretakers. So I've gone on a bit of a tangent there, but if you're interested to read more, we can link to the paper in the podcast notes and the JCVI statement, which explains the rationale behind the vaccine rollout in much more detail.
Wow, that was very interesting, Rhiannon. I learned something new today. I'm glad I asked you. I think what you said has just cemented my decision to get my twins the vaccine. Doubt they're going to be happy about the jab, though.
It's not too bad.
So what have we learned today? We learned that scarlet fever is still around with its classic sandpaper-like rash and strawberry tongue. Early diagnosis is key. Neonatal skin conditions like baby acne and congenital dermal melanocytosis are common and usually harmless, but the latter needs to be diagnosed with care and documented well. Eczema in children with skin of color can look grey, purple, or ashen instead of red, and post-inflammatory hyperpigmentation can last long after flare-ups. Salicylates and ibuprofen are not recommended for managing the symptoms of chickenpox. And each child in a family who develops varicella has sequentially worse disease, with the final child being the most unwell. And finally, managing itch and infection risk is crucial for both eczema and chickenpox to prevent complications like superinfection and scarring. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. See you next time.